So thank you to the program committee and to Lucas for the opportunity to speak. The title for this topic was assigned to me, and so why X stent? And I guess this would be what the heck stenting maybe would be another category. It's interesting if you look at historically what the percentage of aneurysms are that are treated endovascularly, and for the most recent data that I could find, which was in 2014, still only about 60% of aneurysms were treated endovascularly, and the remaining ones were treated with surgical clipping or other types of surgical procedures. We, since 2014, have some new technologies or technologies that were only recently available, and this number is likely to rise. So one wonders in 2019, where are we going to be? Will it be 80%, 90%? And I think that these complex stenting approaches are ways of increasing the percentage of aneurysms that can be treated endovascularly. I think, though, if you think about it, there's also a lot of cognitive barriers. So looking at these aneurysms, with a show of hands, how many people would treat this basilar aneurysm endovascularly at your institution? Okay, quite a few hands. What about this ACOM aneurysm? Still a lot of hands. And how about this MCA aneurysm? So maybe a few less. The astute among you may have realized that this is actually the same aneurysm in different projections. And the point is that essentially, if you think about a basilar aneurysm, ACOM aneurysm, or MCA aneurysm, they're all essentially the same thing, just rotated. And yet we treat them completely differently. Here's some data to that effect. In the top table, this is data from 2 endovascular slash neurosurgery centers where the lead person was someone who was dual trained in both endovascular and surgical techniques. And if you look at the data, still fully 75% of the MCA aneurysms were clipped at these institutions, 50% of the ACOMs. I think, clearly they might be easier to get to surgically, but there's also a cognitive shift about why do we treat certain types of aneurysms which are really identical to each other in very different ways. There are a couple of case series that have looked at X stents and Y stents, and without belaboring it, I think that in general they show very good occlusion rates and then complication rates that are acceptable but not perfect. So in the first of these studies, they had a 13% symptomatic complication rate. The bottom one is 0% complication rate, but there might have been some luck involved because there is 1 hemorrhage and 2 ischemic events, which didn't lead to clinically significant bad outcomes. So if we're thinking about an X stent or a Y stent in particular, the things that I would be thinking about were, is there one of the branches that can't be protected with a stent and where it's going to be difficult to keep the coils out of that branch? When approaching it, usually we'd like to catheterize the more difficult branch first to make sure that it's feasible. And for larger aneurysms, one danger is to displace the first stent into the aneurysm when trying to cross it in order to place the second stent. I find dual access and simultaneous injections to be incredibly helpful, and I'll show some examples of that. And then another very useful Y stenting or X stenting situation can be as a bailout. So here's an example of the bailout situation. This is a 54-year-old who has a ruptured 8mm anterior communicating artery aneurysm. It's got a nice working projection. And so you see the 3D on the far left. In the middle is the aneurysm prior to treatment. And then on the far right is a situation where I was strongly considering stopping, but I had pretty good catheter purchase and decided to place 1 more coil. So the coil started to go in. I wasn't necessarily happy with where it was going, and then inexplicably to me, the tech decided to detach the coil right at that moment. So now the coil is partially detached, or partially within the catheter still, and so the best I could do is to force the coil into the neck of the aneurysm, which you see is kind of that loose part of the coil on the top left panel. On the top right panel. And then immediately afterwards, the run shows that the A2 on the left side is shut down. So at that point, we placed two Neuroform Atlas stents in a Y configuration. And this is the post-procedure result. Clearly not intended, but all the vessels are open, and the patient did very well with no clinical deficits. Here's an example of an X-stent. This is a 60-year-old who presented with a headache and was found to have a 12-millimeter ACOM aneurysm. So the panel on the right shows catheterization. This is in the days of Neuroform Easy. So there's two XT27 catheters, one from the right side, one from the left side, and then a roadmap image with a simultaneous injection showing the aneurysm and then also the third catheter within the aneurysm itself. So the top panel shows now a kissing X-stent configuration with an SL10 trapped within the aneurysm. The completion angiogram shows some filling at the base of the aneurysm, but it's largely occluded. And then the follow-up MRA at 3 years shows complete occlusion of the aneurysm. Here's another case. This is in the what the heck stent category. So you can see a small superior cerebellar aneurysm in this picture. This patient presented with a thunderclap headache, no subarachnoid hemorrhage, but she had an unrelenting headache afterwards and was found to have this small left SCA aneurysm. Initially, I tried to coil it primarily, but was unable to get a coil to stay inside of the aneurysm due to the wide neck and the incorporation of the SCA into the aneurysm. In this case, we took a trans-PCOM approach, so went through the right ICA into the through the PCOM, the right PCA, and catheterized the left superior cerebellar artery while trapping an aneurysm with trapping a catheter within the aneurysm. This next picture shows an Elvis stent from right PCA to left SCA, and then progressive coiling of the aneurysm with complete occlusion of the small left SCA aneurysm. So in conclusion, I think that most important, we need to think about the cognitive shift that's necessary when considering treating these bifurcation aneurysms. Thanks.